Well, it's not really how hemoadsorption influences decisions, but what is our decision is based whether or not to start hemoadsorption. And it is a very difficult question. At the moment, my approach and our team's approach is it's basically the clinical picture that is the leading in our decision making. And the right moment when to start hemoadsorption is when after a certain period of time of standard treatment, the patient is not responding. And the key in this is hemodynamic instability. So if we cannot reverse hemodynamic instability, this is the right time when to start hemoadsorption. Everything is usually happening at the same time, but the most prominent change is the improvement in hemodynamics. So we are able to reduce the vasoactive support, mainly the vasopressor support in these patients. It is also accompanied by reduction of certain inflammatory biomarkers, mainly because of direct absorption by the device. And it could also be a part of on inflammation, which is reflected in reducing circulating biomarker levels. But we also saw improvement in oxygenation in patients who received that treatment with severe ARDS. Our main target in the treatment is hemodynamic instability. So as I said, after standard of treatment, meaning fluid resuscitation, vasoactive support, invasive hemodynamic proven vasoplegic shock, this is the time when we start the treatment, to be honest, irrespective of the biomarker response or biomarker levels. But biomarkers are an important signal that the patient is in dysregulated host response state. Well, there are several questions I would like to answer, but possibly the most intriguing for me at the moment is to finding the link between reducing circulating biomarker levels, improvement in hemodynamics. So what is the link between the two? And our current hypothesis is endothelial protection. So by removing inflammatory biomarkers and toxic materials, we may just regain control over a damaged endothelial surface, which is responsible for loss of vascular tone, capillary permeability, and organ dysfunction. So this is our goal in the not too far future, to investigate the effect of hemoadsorption on endothelial protection. Well, cost effectiveness is indirect, obviously. So if we can reduce the need for organ support, in other words, if we increase the organ support free days by hemoadsorption, by faster enhanced improvement in circulation, enhanced improvement in oxygenation, then we can limit vasopressor support, we can limit length of mechanical ventilation, and at the end of the day, the patients can get out from the intensive care unit faster. Every day less ICU stay has a huge cost effectiveness effect. If you treat your patients and you do the best, and you see that there is a chance for that patient to survive, but not responding to standard medical therapy, and you are quite certain that the reason of the critical illness is hyperinflammation, consider doing adjuvant hemoadsorption as a little extra help for your patients.